Our topic is about fracture dislocation, shoulder and fracture proximal humerus. The most susceptible sites in the upper limb to trauma and injury is the clavicle, scapula, shoulder joint, humerus, elbow joint, forearm bones which including the radius and ulna, wrist joint, and one of the most important carpal bones susceptible to injury, which is the scaphoid. The mechanism of injury of the upper limb, mostly indirect, commonly described as a fall down outstretched hand. You can see the figure on the slide for how we fall down an outstretched hand to protect our body during accidental fall. The type of injury and site of injury in the upper limb depends upon the position of the upper limb at the time of impact. Either it's flexed, extended, ADD abducted, or ABD abducted, pronated, or supinated. First, we are going to talk about the clavicle, fractured clavicle. The common age is the extreme of age. We mean the children and elderly patients. The commonest site is the middle third. As you know, the clavicle is a tubular bone. We have the lateral 1/3, which articulate with the acromion, making the acromioclavicular joint, and we have the medial third, which articulate with the sternum, making the sternoclavicular joint. It's mainly due to indirect injury. If it's direct injury, it leads to comminuted fracture. It means multiple butterflies. The left figure is clinical photo for a patient. You can see the step it's manifested. This step is by the medial fragment, which you can see it on the right figure, which is plain X-ray, showing the medial fragment is directed upward and the lateral fragment is directed downward. Most of the time, the fragments at both sides of the fracture, the deformity is depending about the muscle attached to each fragment. As regard to the treatment of fractured clavicle, as usual, it's conservative management or operative management. As regard to the conservative management, it includes broad arm sling, it includes figure of 8 bandage, but the operative fixation or the open reduction and the internal fixation indication is open fracture, neurovascular injury, or non-union. Actually, the conservative management for fracture clavicle, it's decreasing in the last decade because most of the fracture clavicle unite. Non-union is rare, but mostly unite in a malposition. So the end result is malunion. This is examples for the conservative management. You can see the uppermost figure. It's the figure of 8 bandage. And on the right side of the slide, you can see a method of the internal fixation, which is plate and screws. Of course, you can fix it with medullary fixation, some kind of like K-wires or interlocking, special interlocking implant for the clavicle. Second item is the dislocation of the shoulder. Mostly the dislocation of the shoulder is anterior, more than 95%. The posterior dislocation accounts for less than 5%, but the true inferior dislocation occurs in less than 1%. Okay, this is the post-traumatic dislocation of the shoulder. So, what's meant by habitual dislocation of the shoulder? It's non-traumatic dislocation, which may present as multi-directional dislocation due to generalized ligamentous laxity, and usually it's painless. The mechanism of anterior dislocation of shoulder, as we mentioned before, it's indirect fall on abducted ABD and extended shoulder. It may be direct when there is a blow on the shoulder from behind. This is a figure of the anatomy, drawing anatomy. You can see the head when it's getting out of the shoulder joint. The most common lesion is Pankart lesion. Clinically, this is the clinical picture. You can see the patient in pain and hold the injured limb flexed. The shoulder is abducted. There is loss of normal contour of the shoulder. Here is clinical picture. You can see the gap, and you can palpate it above the dislocated head of the humerus. Here you can compare between normal side and the dislocated right side. This is radiological assessment of the dislocation shoulder. You can see on the X-ray the position of the head of the humerus while it's dislocated. Sometimes there is associated injury with the anterior dislocation of the shoulder. Injury to the neurovascular bundle in the axilla, but it's rare. The little bit more common which is injury to the axillary nerve, but it's usually temporary. Sometimes it's neuropraxia due to stretching on the axillary nerve in its pathway. And also, maybe there is associated fracture dislocation, so we call it fracture dislocation. Dislocation of the head of the humerus with fracture greater tuberosity, surgical neck, anatomical neck, etc. This is the figure of the pathway of the axillary nerve, which is mostly susceptible to be stretched during dislocation of the shoulder, anterior dislocation. Of course, the deltoid muscle is supplied with the axillary nerve, as you know, but also the axillary nerve is mixed nerve, so it has sensory function. It supplies the lateral aspect of the shoulder. You can see here in this clinical figure. We usually call it the policeman tag site. You know, the tag of the policeman on the lateral aspect. You can test it to the patient to the dislocated side compared with the other side. If there is hypoesthesia or loss of sensation, so you can confirm that there is affection of the axillary nerve. Management of the anterior dislocation is reduction. Of course, reduction. It's an emergency and should be done within the first 24 hours, because if it's delayed, it increases the possibility of avascular necrosis of the head of the humerus. And following reduction, the shoulder should be immobilized for 3 to 4 weeks till soft tissue healing, because the first dislocation of the shoulder management, it's really important for each patient, because it's according to that, it's depending upon the most common complication of dislocation shoulder, which is recurrent dislocation shoulder. Methods of reduction of the anterior dislocation shoulder. It's 3 famous methods. One of them that we are using in the hospitals. So, as historically, you have the Hippocrates method. It's a form or necessitating a form of anesthesia or bone abolishing is required. Stimson technique, usually done in cases, neglected cases for a time. Kocher technique is that what we are using in the hospital under general anesthesia and muscle relaxation. This is a figure for Hippocrates method. You can see the foot of the surgeon in the axilla of the patient and doing traction on the upper limb at the start on the direction of the deformity side till relocating the head with the foot, and then doing abduction, internal rotation, and immobilizing the patient. Stimson technique, as we said, it's for chronic cases doing traction to the upper limb. It's obsolete, we don't use it right now, but it's as to be mentioned as historical. This technique for closed reduction is what is generally used in the hospital. You can see from the left to right the step 1, step 2, step 3, and step 4 for the reduction. First you do traction in the deformity position, and then you go for adduction, ADD, while external rotation, and then you go for internal rotation, and that will relocate the head of the humerus in the shoulder. Complication of the anterior shoulder dislocation. We put it in early complication and late complication. Okay, for the early complication, it's neuromuscular injury, which is rare. And as we mentioned before, stretching on the axillary nerve or axillary nerve injury, and we can test it by checking out the sensation on the area supplied with the axillary nerve, or associated fracture of the neck of the humerus, greater or lesser tuberosity. That's why we call it fracture dislocation shoulder. Late complication. Late complication includes a vascular necrosis of the head of the humerus, heterotopic calcification, and recurrent dislocation. We mentioned that recurrent dislocation is susceptible for the patient with insufficient or incompliant of the patient, insufficient management or in compliance of the patient. Fracture of the proximal humerus. It includes, proximal humerus include the surgical and anatomical neck, and shaft and distal humerus. It's going to be in the frequent lectures. But for the proximal humerus, you have the surgical and anatomical neck. Here is an example for fracture proximal humerus, the upper third. You can see it on the left side, the radial X-ray without immobilization. On the right side, you see it immobilized with external slab. This is examples for internal fixation, open reduction and internal fixation with plate and screws to the left side and with rush pins or medullary wires and insertion on the right side. Another example for intramedullary K-wire fixing proximal humerus fracture. Fracture of shaft of the humerus, it's commonly indirect. Indirect injury result in spiral or oblique fracture. Direct injury result in transverse or comminuted fracture. It may be associated in that site with radial nerve injury, because as you know, the pathway of the radial nerve injury, it passes in the spiral groove, starting at the proximal little bit to the middle third and going all the way around on the middle third of the humerus. This is a brain X-ray giving an example of fracture shaft humerus susceptible for radial nerve injury. Actually, if the patient presented with fracture humerus with radial nerve injury, you can find wrist drop associated with fracture humerus in up to 12% of fracture. 2/3 of the radial nerve injury with fracture humerus are neuropraxia, and 1/3 are nerve laceration or transection. How we can manage as general for the radial nerve injury as a separate entity after managing or during managing the fracture humerus. You can check it with EMG, nerve conduction, plus to clinical, so you can repair it, or in late cases you can do muscle transfer. In general, managing the fracture humerus, you can have again conservative management by closed reduction or open reduction and internal fixation. Closed reduction in upright position followed by application of a U-shaped slab or slender cast. We are going to see clinical or a figure for that. Few weeks later or initially in a stable fracture, functional brace may be used. This is a figure for the U-shaped slab and functional braces. Another figure for functional brace. Indication for open reduction and internal fixation for fracture shaft humerus. Failure to reduce it conservatively, and it's depending about the pattern of fracture. Either the pattern of fracture is stable or unstable. Bilateral fracture humerus, open fracture, unconscious patient, delayed union, non-union, or malunion. This is an example for internal fixation with plate and screws. Another example for modular fixation with K wires. Thank you very much.